Thalassemia is an hematologic disease. Look at this picture shows that normal red blood cells and thalassemia red blood cell and types alpha thalassemia and beta thalassemia. Look at these pictures. A detail going on. Introduction. Thalassemia is a genetic blood disorder characterized by the body's inability to produce adequate hemoglobin, the protein in red blood cells responsible for carrying oxygen throughout the body. This results in anemia, a condition where there is insufficient oxygen delivery to the tissues. It is particularly prevalent in Mediterranean, Middle East, Southeast Asia and Africa, but occurs globally due to migration. A definition: thalassemia is a group of inherited blood disorders caused by genetic mutations affecting the production of either the alpha or beta chains of hemoglobin. It leads to reduced or absent hemoglobin synthesis, causing chronic hemolytic anemia. Types. Thalassemia is primarily categorized into two major types. A. Alpha thalassemia results from a defects in the genes controlling the alpha globin chain production. It's classified into one alpha thalassemia carrier, mild, often asymptomatic. 2. Alpha thalassemia trait, mild anemia. 3. Hemoglobin H disease, moderate to severe anemia. 4. Hydrops fetalis, fatal, occurs when all the 4 alpha globulin genes are mutated. B. Beta thalassemia results from mutations affecting the beta globin chain production. Classified into 1. Beta thalassemia minor, carrier state with mild anemia. 2. Beta thalassemia intermedia, moderate anemia, does not require regular blood transfusion. 3. Beta thalassemia major, severe anemia, requires lifelong blood transfusions. Causes. Thalassemia is caused by mutations in the genes responsible for producing hemoglobin chains, alpha or beta. These mutations can either reduce or completely stop the production of the affected globin chains, resulting in a imbalance of hemoglobin formation. One alpha thalassemia caused by deletions or mutations in the HbA1 and HbA2 genes on chromosome 16. 2. Beta thalassemia caused by mutations in the HBB gene on chromosome 11. Risk factors. 1. Family history. Having a parent or close relative with thalassemia increases the risk. 2. Ethnicity. Individuals of Mediterranean, Middle East, Southeast Asia or African descent have a high prevalence. 3. Genetic carrier state. Inheriting the defective gene from one or both parents determines the severity. Complications. 1. Severe anemia can lead to fatigue, weakness and complications in major organs. 2. Iron overload. Frequent blood transfusion can cause excess iron, leading to damage in the heart, liver, endocrine glands. 3. Spleen enlargement. Splenomegaly can cause additional anemia and a need for splenectomy. 4. Bone deformities. Overactive bone marrow trying to compensate for anemia can result in bone deformities. 5. Growth retardation. Delayed puberty and stunted growth are common in children with severe thalassemia. Pathophysiology. In thalassemia, the defective gene leads to the underproduction of one of the hemoglobin chains, alpha or beta. This causes an imbalance between alpha and beta chains, resulting in the formation of unstable hemoglobin that precipitates inside red blood cells. The affected RBC are destroyed prematurely in the spleen, causing hemolysis and anemia. The body compensates by increasing erythropoiesis, production of RBC in the bone marrow and other tissues, leading to bone deformities and enlargement of organs such as the spleen. Step-by-step process. 1. Genetic mutation. 2. Imbalance in hemoglobin chain production. 3. Defective hemoglobin formation. 4. Ineffective erythropoiesis. 5. Hemolysis. 6. Anemia. 7. Bone marrow expansion. 8. Extramedullary hematopoiesis. 9. Iron overload. 10. Organ damage. 11. Chronic hypoxia. 12. Spleen enlargement and splenectomy need. Signs and symptoms. 1. Fatigue and weakness due to anemia and lack of oxygen transport. 2. Pallor, pale skin, mucous membranes. 3. Jaundice, yellowing of the skin and eyes due to increased breakdown of red blood cells. 4. Delayed growth and development, especially in children with severe forms. 5. Bone deformities, facial and skull abnormalities due to marrow expansion. 6. Dark urine due to hemolysis. 7. Enlarged spleen, as the spleen works harder to filter abnormal RBCs. Diagnosis: A. Blood test. 1. Complete blood count CBC shows anemia, small and pale red blood cells. 2. Hemoglobin electrophoresis detects abnormal type of hemoglobin. 3. Iron studies rule out iron deficiency anemia. B. Genetic testing identifies mutations in the hemoglobin genes. C. Prenatal testing. Amniocentesis or cryonic villus sampling can detect thalassemia in a fetus. Nursing diagnosis: 1. Impaired gas exchange related to decreased hemoglobin levels. 2. Risk for infection due to splenectomy or iron overload. 3. Risk for activity intolerance due to fatigue and weakness. 4. Chronic pain related to bone deformities and marrow expansion. 5. Imbalanced nutrition less than body requirements due to poor appetite or disease complications. Management: 1. Monitoring regular assessment of hemoglobin levels, iron overloads and organ function. 2. Blood transfusion to maintain hemoglobin levels and reduce complications. 3. Iron Solatin therapy to prevent iron overload from transfusion. 4. Folic acid supplementation helps in RBC production. 5. Splenectomy in case of splenomegaly causing complications. 6. Bone marrow or stem cell transplant, the only curative treatment mainly in severe cases. 7. Hydroxyurea used to increase fetal hemoglobin production in some cases. Treatment: A. Pharmacological. 1. Iron chelators such as D-ferroxamine, D-ferroxyxerox and D-ferriferone to manage iron overload. 2. Pain management and antibiotics for managing infections. B. Surgical bone marrow transplantation for eligible candidates. 2. Splenectomy for those with severe splenomegaly. Psychosocial medicine. Thalassemia affects not just the physical health but also the emotional and psychological well-being of patients. Psychosocial care should focus on 1. Supportive counseling to help patients cope with chronic illness, especially children and their families. 2. Education about the disease, its management, and genetic counseling for families. 3. Social support. Connecting with patient support groups can help individuals feel less isolated. Prevention. 1. Genetic counseling essential for individuals with family history of thalassemia who are considering having children. 2. Prenatal screening can help identify carriers and provide options for managing pregnancies. 3. Marriage screening programs. In some countries, programs aim to reduce the prevalence by informing couples of their carrier status. In conclusion, thalassemia is a complex inherited blood disorder that can have significant impacts on patients' quality of life, while curative treatment options like bone marrow transplantation are available. Management primarily involves lifelong supportive care, including regular transfusion, iron chelation, and careful monitoring. Advances in genetic testing and prenatal care can help reduce the prevalence of severe cases through early detection and counseling. Thank you. Have a nice day.